Hello and welcome. This is Abigail Perillo from the CHESS Program Development Team. We'd like to thank you all for attending today's webinar, utilizing blood-based biomarkers in the evaluation and management of pulmonary nodules. So these are the disclosures that Dr. Silvestri has to show. So today, Dr. Silvestri will be reviewing the diagnostic approach to distinguish benign from malignant disease. He will discuss when to choose surveillance, lung biopsy, PET scan, or surgery for the management of lung nodules. And lastly, he will introduce how blood biomarkers will potentially be used in this space. Before I pass it over to Dr. Silvestri, I'd just like to go over a few housekeeping items. All questions will be held to the end of the presentation. And as well, if you do have any questions, I please ask that you enter them into the question dropdown in the GoToWebinar panel. All right, and I will pass it over to Dr. Silvestri.
Well, good afternoon, everyone, and thank you so much for joining us for this webinar. I want to thank the folks at CHESS for getting us all taken care of from the technical end, and also Biodesics, who's sponsoring this in conjunction with CHESS. And I also want to say hello to all the folks on the line. I got a chance to look at the roster of folks, and I know some of you, and I'm wishing everyone around the country well, particularly through this COVID crisis. I hope everyone stays safe, keeps their families safe, and let's continue to get all through this all together. So I want to talk to you today about pulmonary nodules, and honestly, over the course of the last 15 or 20 years when I've been studying this, it really started to focus my question. And when it really comes down to it, what is the singular question that we're really trying to answer when we see patients in our clinic with nodules? And it is, here's a typical x-ray of a spiculated pulmonary nodule, and really the question we always ask ourselves is this. It's a simple question. Is this cancer or not? And that really dictates what we do. And when I talk to patients, I say, look, does this look like, for me, my job is to tell you whether this is cancer or anything else, because anything else, we have the ability to sort of be more deliberate, be slower, not do as much invasive testing. But if it's cancer, we certainly want to get them to the operating room and get it out. So there are really three management alternatives: surgery, when in doubt, cut it out; biopsy when cancer is the answer, tissue is the issue; and wait and watch. Don't just do something, stand there. And I'll tell you, if you don't take much away from the rest of this talk, my clinical practice, where I see 4 to 6 new lung cancers a week and now more and more pulmonary nodules, I've really learned to sit on my hands and really wait it out a little bit. I'm much more likely to observe than I was in the past. And one of the things I thought about a lot in how physicians manage nodules is confidence. I see only lung cancer and pulmonary nodules, and so for me, I'm a little bit more confident about whether I think this is cancer or not. And I hope that clinicians throughout the country who are dealing with asthma and COPD and tuberculosis and sarcoid and see nodules maybe once or twice a week can get more confident in their management of this disease. And so really almost the first step is to have this idea, this sort of detective work in your mind of whether this nodule is cancer or anything else. And we do that by assessing the likelihood of malignancy. And you can use either risk calculators, we're going to go over that, or clinical judgment, which is just as good, if not better. And in the low risk nodules, less than 5%, Michael Gould through the ACCP guidelines will tell you, you should really just watch those. In the middle group, intermediate group, this is the tougher group, and this is a group I'm going to be talking about a lot today. And that's where most of the patients end up if you use the calculator. You can then do either a PET scan or a biopsy, either transthoracic or bronchoscopy, and we'll review those. And then if it's high risk, you can take them straight off to surgery and resect the nodule. So if you think the risk is more than 65% or higher, you can take them straight to surgery. And so how many nodules are there in the United States? It turns out there are about 1.5 million nodules in the United States. And of those that are cancer, 30 millimeters or less, which is the definition of a pulmonary nodule, 70% of the lung cancers have a nodule at the beginning that's that's 70,000, excuse me, have a nodule that is less than 3 centimeters in size. So it's an important problem, and it's an increasing problem. And as we do more CT screening for lung cancer, we're going to find more and more nodules. Many patients can't get through the emergency room for a complaint of chest pain without getting a triple rule-out scan to look for pulmonary embolism, only to turn out to have a nodule. A lot of those are benign nodules, and we'd like to avoid doing any further testing in those patients. And so a long time ago, I sort of sat down with my lab and we put together some of the work we had been doing in nodules, and I drew it on a napkin and someone made it in a much nicer slide for me. But there are different areas that people have worked in within nodules: radiomics, risk predictors, bronchoscopic diagnostics, genomics and proteomics, and volatile organic compound expression. I'm not going to speak about that today, but it's in literature I hope you keep an eye on because there's some exciting things going on there. So let's start with looking at risk prediction calculators. And so the commonest ones, these are clinical intuitions. One, just what do you think this is? I'll talk about one study from our lab that looked at that. And there were really some great validated models. The VA model, the Mayo Clinic or Swenson model, and the Brock or Martin Tamimagi model. What I like to alert people about when they're using these clinical predictors or modeling exercises is that the prevalence of cancer in those models differed greatly. So for example, in a VA model, the cancer prevalence rate was 40%. So using that model in someone in a screen detected population is probably not going to work so well, because if you look at the bottom one, the Brock model, that malignancy rate was 3 to 5% and not that high. And so you want to make sure that you're using the right model. The Mayo model is the one that's most commonly used. If you plug into your Google solitary pulmonary nodule calculator, the one that comes up most often is the Mayo model. And the prevalence rate of malignancy there is about 25%. When you're seeing incidental nodules in your clinic throughout the country, I suspect it'll be about a quarter of them that by the time they make it to a pulmonologist for evaluation, about a quarter of them will be malignant, which suggests that we really need to differentiate those from the 75% or so that are benign. And this is the Mayo model, and it really is a good model. It's pretty simple to use, and again, you can plug it into a computer. It looks at age and smoking and a history of extrathoracic malignancy. You know, again, older age, more likely to be cancer. Smoking history, more pack years, more likely to be cancer. And if you have malignancy elsewhere, it's more likely that what you're seeing in the lung is cancer. And then there are radiographic characteristics: diameter, larger size, more likely to be cancer; spiculation, more likely to be cancer; and upper lobe location. 2/3 of lung cancers are seen in the upper lobe. And a really famous statistician once said, all models are wrong, but some are useful. I think this is an incredibly useful model, and it's simple to plug in those numbers in a computer and have it spit out the risk of malignancy. So we actually did that, and this is a study from 5 years ago, Nicole Tanner in our lab and myself and others. What we wanted to do was look at this sort of nodule odyssey, and we looked at community pulmonologists throughout the country. It was a multi-center, 30-site trial where we looked at the odyssey of patients that went through all aspects of looking at pulmonary nodules. And what we did after the fact, after we looked at what they did, is we calculated the risk via the Swenson model of what their actual pretest probability of malignancy was, and then what the doctors did with that. And so what you can see here is there were about 36 out of that 377 that had a risk of cancer of less than 5%. Not surprisingly, the model did well at predicting. All of those were benign. The intermediate group, again, this group of intermediate risk, 5 to 65%, there were most of the patients fell into this group, and the malignancy rate was about 25%. And then the high-risk group, interestingly, the model didn't work so well in the high-risk group, where 55% were still benign, which, you know, I wonder if we shouldn't, when we redo our guidelines, push that up to about 80% before you send someone to surgery, because we certainly don't want more than half the people with benign disease being pretest calculated out over 65%. The amazing thing about this trial is what you should see in this trial is for those with benign disease, they all should be looked at with surveillance. Now, more than half had surveillance, but look at this, 17% or 6 of those patients underwent surgery and 28% underwent some type of biopsy. And the surgery rate was exactly the same between those with low, intermediate, and high risk lesions or high risk nodules. That shouldn't be like that at all. It should be decreasing, increasing surgery as the risk goes up. Interestingly, biopsy rates did go up, but not statistically significant. It was only a trend. And surveillance rates did go down as the risk went up, but again, not statistically significant. So we weren't really sure why that was. We reckon that pulmonologists may not routinely consider the probability of cancer, although again, with the trends of surgery going up as the risk went up and biopsies going up as the risk went up, they must be thinking about that somewhat. They were either unaware that the guidelines existed or they just didn't believe in the evidence following the guidelines and chose not to follow them. One thing we don't know is what patient preferences played into this, and so it's possible that patients might have said, hey, look, like I know you're telling me that I should just follow this, but my grandfather had cancer, and unless you can give me 100% certainty, I want this taken out. 44% of the very low-risk patients underwent an invasive procedure for benign nodule. And you know, that's problematic for me. I'd like to see those surgical rates be well less than 10% in patients with benign nodules. We went back at this in a different trial. We were able to look at physicians' pretest probability of malignancy. So how do physicians predict cancer? And so this was part of a larger trial I'm going to share with you later, but it was 337 patients, and the physicians were able to bucket that before they knew what the outcome of the patient was into by every 10% bucket. And what we found was that, you know, physicians actually are better than the Mayo model. So you can see here the receiver operator curve. The area under the curve for MDs was 0.84, Mayo Clinic model 0.77, and the VA model 0.74. And so docs are actually quite good at figuring out whether somebody has a malignant or benign nodule. I think the problem is that they don't always act on it the same way as they predict for it. And so they do a little bit too much testing in patients with benign disease. And again, we really don't exactly know why they're not following guidelines. I actually suspect some of this is confidence. You know, maybe one time they got burned with a nodule that they followed that turned out to be malignant. Maybe patients pushed them a little bit. We don't know exactly why that is, but I think if they were a bit more confident in their assessment of pretest probability of cancer, they might follow the guidelines a little bit more. And so I want to switch gears for a second and get into radiomics. Radiomics is an area that I think is really coming alive, particularly with the recent results of the Nelson screening trial from Europe, which supported the NLST trial for lung cancer screening. Randomized trial found a reduction in cancer death among those screened with CT. Interestingly, the Europeans are using radiomics a lot more than the United States to look at growth in pulmonary nodules. How good is the cursor measurement? This is where we look at patients and we spread the caliper across and we measure from one side to another with these nodules. This is a really cool study where they took 33 patients with lung cancer and they actually had them go into the same CT scanner, lay there, have their scan done. These are people with no nodules, and then get up, walk around the office a couple times, come back, lay down on the same CT scanner in the same position with the same technologist and get their CT scan repeated. And then radiologists were blinded and asked to read those CTs, and they were separated in time. When they looked at those, they actually showed something, it's almost laughable. 57% had 1 millimeter difference in growth. Again, these were 15-minute scans apart. 33% or a third had 2 millimeters of difference. And when they read those scans, 23% read that there was shrinkage and 33% read that there was growth. If you look at the plots of this, what you'll see that some read them even up to 7 millimeters difference. Now listen, like, we may all laugh at this and say, you know, the radiologists, gosh, they're funny folks. But when you're having a patient where decision making has to be performed, then you might say, look, we're going to do a biopsy if on the next scan this grows. You know, there's not a lot of precision in looking across those calipers. And so I think we should be aware that even a change of 4 millimeters in diameter to 5 millimeters in diameter is a full volume doubling in 3 dimensions, and same going 5 to 6.2, et cetera, et cetera. This is a tumor doubling in size over that same time period. And so it's incredibly important that we get accurate measurements. And the Fleshner Society is now telling us that we have to do both a short and a long axis measurement for all of our nodules and report it that way, so we have some semblance of precision if we're going to use that metric. However, I think there's maybe a better way, and I think that's going to be coming to radiology theater near you sometime in the next few years when it becomes more practical. And this is a patient who I thought had a relatively suspicious nodule, was lobulated and spiculated, but the patient was elderly, and they said, look, let's just follow this. And in March of 05, the nodule was 1.3 centimeters, and in September of 05, it was sort of 1.5 centimeters. I didn't know whether that was within the error of the test, so I asked my radiologist to do volumetric measurements. And so this is a 3D reconstruction, and what you see is this patient actually went from 787 millimeters cubed to 1,334 millimeters cubed, or a full doubling, even though there was a very small change in size when you looked at moving the cursor across. And so, you know, I mentioned this, and this is something that can be done on all of your nodules if they keep the thin slices through the nodule between scans. And so you can ask your radiologist to reconstruct this. They have to go offline and use another software package, but they can do it. And why is it important? This is a New England Journal article by Rob Van Cleaver, where they looked at the nodules from the Nelson trial. This was even before the results of the Nelson trial were reported this year. And what they said was, look, if about half of their scans, CT screens, had no nodules, about some of them were really tiny. There was this group of indeterminate nodules, 5 to 500 millimeters cubed. But this was the interesting part. They had everybody come back in 3 months and repeat their scan. 95% of the indeterminate patients had nodules that had either resolved at 3 months or had no growth, which they said was less than a 25% doubling time. And if they use that as criteria for growth, the sensitivity for lung cancer was really high at 95%, but the negative predictive value was incredibly high. So if there was no volumetric growth in 3 months, these patients were, by and large, benign. Now, it doesn't mean they didn't keep following them, but they didn't do any invasive testing on that group. And so something I think to keep in mind as time goes on. Now, imagine, if you will, if you could add to that the Swenson model or some other model. And our lab did that a while back here in Meta, one of my former fellows, and we added the Swenson model to volumetric measurements that we had from our nodule clinic, and we could improve the classification of malignancy from about 60% in the Swenson model to about 88% when we utilized data from volumetrics. I bring that up because I think what we're going to see as time goes on in this talk, but as time goes on in our investigation of pulmonary nodules, what we're going to see is people using data from different silos, volumetrics added to prediction modeling, maybe added to a biomarker as time goes on. So what I'd like us to do is break down the silos of those round circles I showed you around the nodule that was in the middle. How about PET imaging? So, you know what, I get a lot of questions about PET, and I actually am not a huge fan of PET for solitary pulmonary nodules. I'm an incredibly big fan for using it to stage lung cancers, to look for metastatic disease. And so if I have somebody with a really high-risk nodule that I know is going to surgery, that's when I'll utilize a PET scan. My problem with PET scanning is the sensitivity is okay. The specificity is not great, though, and you get a lot of false positive PETs in patients with benign nodules that are granulomas in nature, focal pneumonia, sarcoidosis, pulmonary nodule, mycobacterium avium complex, etc. And so you see false negative results in those nodules that are small, 8 to 10 millimeter nodules, and those that are well differentiated adenocarcinomas, what used to be called BACs, and carcinoids. They can be these incredibly gross, slow-growing malignancies that won't turn up on PET. So those are the false negatives. On the other side of this, the false positives are, are granulomatous infections and inflammation, as I discussed before. So I am not a big fan of PET for differentiating pulmonary nodules. Now, I will use it on occasion if I have these next few parameters. Which are if I am looking in a patient that's not operative, and I want to send them for stereotactic body radiotherapy, and I want to assess to see if they're hot on PET and a growing nodule. If I suspect a benign disease and I want to get it as a true rule-out test, I'll occasionally do it, and if I want to stage it for lung cancer. So again, this is our little pictorial of what I like to surround a pulmonary nodule with. I talked about trying to add Radiomix and risk prediction calculators. For a second, I want to now go through bronchoscopic diagnostics. And before I get all the hate mail, what I'm about to present to you is that, bronchoscopy hasn't really been great for pulmonary nodules. And I think there's a ton of work going on with guided bronchoscopy, with robotics, with better instruments. But honestly, I'm not quite sure we're there yet. And so I want to share some of the literature around why I think we're not there. And actually is a tale of two sort of eras in presenting this data. And our lab's been involved in both eras. And so while I can criticize some of these data, I take a chance to criticize ourselves because we've published some of this data. If you look at the 2013 guidelines by Patricia Rivera, what you'll see is that for central lesions, bronchoscopy is fantastic, but for peripheral lesions, which is where most nodules lie, it's still pretty good, 78, 80%. However, when you start to break it down by size, when you get to these smaller size lesions, what you see is that the yield goes down a little bit. We looked at this in a meta-analysis in 2012, looking at just pulmonary nodules and looking at guided bronchoscopy, so electromagnetic navigation, peripheral ultrasound, CT guidance, etc. And what we found was the overall yield in about 3,000 patients in 39 studies was about 70%. And that number has sort of been put forth in the literature. When you get down to a small size, it's a little bit lower. I'll tell you that we're updating our meta-analysis right now and using very strict criteria for pulmonary nodule evaluation. Pathologic criteria, and the overall yield hasn't really changed much. In fact, it might have gone down a little bit. So I don't know that that's the case, but I want to show you some more recent studies, 2015 through 2018, and what we see here is a 15-site study for the Acquire Data Registry published in Blue Journal. Really showed that it's actually, if you look at 531 patients, community and academic sites, this prospective registry found the yields more like 40 to 60% rather than 60 to 80%. If you look at the AGES study, which I'm going to show you in a little bit, the overall diagnostic yield is about 53%. And then our lab was involved in a multi-center trial, prospective, randomized, well-defined endpoints, where we compared good old-fashioned standard bronchoscopy with fluoroscopy for 1 to 5 centimeter lesions with a thin bronchoscope and peripheral EBUS. Peripheral EBUS and thin bronchoscope was better, but it's only 50%, and the overall yield was 44%. I can tell you that using bronchoscopy with fluoroscopy alone for pulmonary nodules, probably not worthwhile at all at about a 37% yield. What's the difference between these trials? These newer trials are prospective, either large observational studies, multi-center, as opposed to the other slide I showed you, where what you see is a lot less, they're sort of smaller single-site studies done by experts in the field who are interested in that technology only, and those are added together to produce a meta-analysis which just adds these single-site retrospective studies. And even though I believe the yields from those studies, because they're experts in the field like Felix Hirth in Germany and Alex Chen at WashU, I'm not sure that that's translates to the community. So at the end result is I think we've got to get better with bronchoscopy before we utilize that in our quest to diagnose pulmonary nodules. How about CT-guided biopsy? From Michael Gould's practice guideline 2013, there was about 11 studies. The median sensitivity is 90%. I will tell you though, when I talk around the country, I hear from lots of hospitals and lots of academic medical centers, they don't completely believe that yield. They think that, you know, there's a lot of cherry picking going on. The range is actually 65 to 94%. I think that range is probably about more correct than the absolute number. Specificity is very high. The non-diagnostic biopsies are actually a lot more common in benign disease than they are in malignant, but it doesn't rule out malignancy. Pneumothorax rate from Renda Wiener's study of about 15,000 patients is about 15%, of which 6% require a chest tube. You know, I don't use transthoracic needle aspirate unless I really think it's a specific benign diagnosis, or the patient's inoperable and I need tissue to send them to stereotactic body radiotherapy, or the patient says, hey doc, you got to prove to me this is cancer before I let a surgeon cut into me. So that's when I used needle biopsy. And these are the sort of the same things that are recommended for by the college. What I will say is there's another indication when the tests, pretest probability says one thing, but imaging says another. For example, pretest probability cancer is high, but the lesion's not hypermetabolic on PET, and you see that with, for example, slow-growing adenocarcinomas. So I think this is what folks maybe got online for, and now I want to take you through the world of genomics and proteomics, which has really been a fascinating science, and it's just, I think, pulling itself into prime time now. And I'll share with you some studies of national trials that look at genomic classifiers and proteomic classifiers to help us distinguish benign from malignant disease. So where would they fit? Pretest probability of cancer and where a biomarker might fit best. I think we've kind of set this up to say, hey, look, most of the patients end up in this area where you have to do another test before you can get some kind of definitive answer. And that test is either a PET scan, a biopsy with needle biopsy, or bronchoscopy. And again, most of the patients live in that bucket. My goal in research and sort of in my clinic operations is to push those patients into either the surgical bucket if they have cancer, or serial CT if they don't have cancer. And so what you'd like to do is see or rule out biomarker. Biomarker says this is likely benign, and in that case we'd shift them to surveillance. And if we could have a rule in biomarker, we could shift them quickly to surgery. And so we should review what biomarkers are currently available and what's coming down the pipe in a moment. And so this is a study I was lucky enough to be a principal investigator for, along with Avi Spira from Boston University. And this is the bronchial genomic classifier for the evaluation of lung cancer. And so the rationale was, you know, listen, we've just said bronchoscopy is often non-diagnostics, and patients with pulmonary lesions leading to more testing, either surgery or a needle biopsy, et cetera. We want to evaluate the effectiveness of a bronchial genomic airway gene expression classifier to the diagnostic performance of bronchoscopy. Well, what is that? The concept behind this is that normal epithelium away from a lesion has maybe a similar genomic a pattern as that of the cancer or not of the cancer, sort of this field cancerization effect. And that was developed by Jerry Brody and Avi Spira at Boston University. And so what we did was we did 2 prospective multi-center studies for patients who underwent bronchoscopy. We went in, and before we did our diagnostic testing, we just brushed the main stem carina on the opposite side from wherever the lesion was. Looked at 639 patients, and again, we didn't have the results of that test we went on to do whatever we might have done with those patients afterwards. One interesting thing was before that evaluation, we all, as investigators, had to provide a pretest bronchoscopic assessment of malignancy risk. Not the Swenson model, just our own gut feeling of whether this was cancer or not. In that study, again, I just shared with you, 43% of the bronchoscopies were non-diagnostic. 35% of those underwent invasive testing. And again, that I think I showed you from our community hospital study, that's around the rate of testing for benign disease. So now 2 separate studies where you have this high rate of invasive procedures for benign disease. In the intermediate risk group, so that's this group of that 5 to 60% or so, 83% of the bronchs were non-diagnostic, despite a cancer prevalence rate of 41%. That's problematic. And again, it suggested to me that we need to do better with bronchoscopy. We got to push that field forward to get better diagnostics so that we can appropriately make a diagnosis of cancer or no cancer in these patients. So in that study, the upper half of this slide, if you looked at the sensitivity of bronchoscopy alone, for those less than 2 centimeters was 55%, 2 to 3 centimeters a bit better, more than 3 centimeters it was a bit better. So we got better with bronchoscopy as size increased. If you look at the classifier alone, it actually was very sensitive at detecting cancer when it was present. And if you combined, and again, this gets at this concept of can we combine pretest probability of cancer, a classifier, and bronchoscopic results. And in this group, it showed that when you combine the classifier with the results of bronchoscopy, a non-diagnostic bronchoscopy, even in lesions as small as 2 centimeters, you had a 96% sensitivity and a very high negative predictive value. So it was a good rule-out test. So this study showed that again, you could reduce invasive testing had you followed the results of the classifier. Now, we didn't have those results at the time, so we didn't know what clinical utility was going to be. All we had was we did the test and sent it off and then did whatever we were going to do on those patients. If you look back and had we acted on that test, we would have reduced invasive testing a lot had we trusted the classifier. So that brings me to the bottom half of this slide. Hans Lee at Hopkins and others, Peter Mazzone, have looked at the impact of that genomic classifier on clinical management decisions. And so in a registry study, they wanted to evaluate physician management post a non-diagnostic bronchoscopy. And in 283 patients at 35 sites, they were able to down classify malignancy about a third of the time. So they had a patient was going in with an intention to look for cancer. They took specimens at the onset. If the biopsies were non-diagnostic, they went ahead and ran the classifier, and then they got the result and were able to act on it. And 73% of the time with this classification, the doctors did change their mind and went to surveillance without further procedures in the majority of patients over the next 12 months. So that's bronchoscopy. And again, I think it's a reasonable test if you're doing a bronchoscopy and you're not sure whether you're going to make the diagnosis. But we don't do a ton of bronchoscopy just for small pulmonary nodules. And so that brings me to a blood-based biomarker. And again, we were awfully lucky to be involved in a national trial to assess a plasma proteomic biomarker to distinguish benign from malignant lung nodules. And this was the PanOptic study, prospective 33-site trial, 685 patients with 8 to 30 millimeter nodules. They combined 2 plasma proteins and part of the Swenson model to identify likely benign nodules. And so this is really a rule-out test. Again, clinician assessment of the nodule pretest probability for malignancy. That's important because this study showed that if you acted on nodules, you want to act on the ones that had a pretest probability of 50% or less. So in that study, 178 of those patients had a pretest probability of cancer 50% or less. The prevalence of malignancy in that group was 16%. The classifier had a sensitivity of 97% and a specificity of 44%. Now again, a rule-out test should have a high sensitivity and an even higher negative predictive value. A rule-in test would have a high specificity. It'd be great if we had one test that could do both. The negative predictive value here was 98% in distinguishing benign from malignant nodules. Again, we did not have the results of that blood test when we did the trial, so we managed them how we would normally manage nodules. Had it been followed, though, to direct care, 40%, again, you get to the same number over and over again. 40% fewer procedures would have been done in patients with benign nodules. Now, there was an expense here. The expense of this was that 3% would have been misclassified as benign, having had a malignant nodule. Now, listen, again, PET scanning has a 10% chance of having a negative PET in somebody with cancer. So this is even less than that. And what I would urge people to remember from this talk today is what we don't want to do is stop following people with a negative plasma test or a negative genomic classifier. You're still obligated to follow these with serious surveillance, you know, and make sure that a slow-growing malignancy is not missed. But again, you could at least get away from invasive testing in these patients. And if you look at the classifier itself, and this was presented in 2018 by Steve Springmeyer, you find out that the 5 parts of the Swenson model, are nodule size, age, smoking history, speculation, and location. And that's the components of those that make up the nodule part. And then the plasma protein actually made up 30% of your ability to predict. The others made up a combined for the rest of the 70%, but the 30% of that was made up by these 2 proteins. And if you look at the receiver-operator curve, this top receiver-operator curve is the AUC for the integrated classifier. It outperformed physicians, PCA, PET, the VA model, and the Mayo model. It outperformed all of those. And so it did seem to outperform the rest of what we usually have in our armamentarium. So this is kind of what would be reported out to you from that test. If a patient starts out with a pretest probability somewhere in that 5 to 50 range, let's just say for this patient example, they had a pretest probability of 30%. And if the post notify, that's just the name of their classifier, it had a likely benign with a negative predictive value of 98%, that would push the patient to have a 3% post probability of cancer, and that's how it would be reported out to you. Now, what's interesting is the company can also report out what's called reduced risk. We as investigators, I think, really insisted on having this very high negative predictive value. That doesn't mean the test is useful at a negative predictive value, between 90 and 98%. You could reduce risk, but again, you might see more malignant nodules pass through. It doesn't mean the information is not valuable, and it might be particularly valuable if you said, look, I have a patient, it's not a great operative candidate, doing a biopsy at a high risk of pneumothorax in somebody with emphysema. I'm willing to surveil them up to a risk of cancer of maybe 10% or 15%, where it's still most likely benign. But this test might, again, show you a reduced risk, and in that regard, help you to maybe put them in surveillance for 3 to 6 months. And so this was a late-breaking abstract. Sadly, they were not able to, Dr. Pritchard and colleagues were not able to present this because ATS was canceled. But Oracle is a larger database, a registry, a prospective registry, where the doctors, in fact, were given the option, were given the test results back. A couple of interesting things. The first thing is, if you look at the Panoptic study, that's the study I just showed you, in 144 patients, the pretest probability of cancer was less than 5%, after the blood test, 55% of those patients had a probability of less than 51%, had a probability of cancer of less than 5%. So you're able to push a lot of patients down that spectrum into the low pretest probability group. What's interesting is in the Oracle study that is just out in abstract, the pretest probability by doctors, that group of less than 5% was only about 2% of the population that they were that came into this study. And they were again able to have, after post-test, about 49% of their patients were now in that 5% or less risk of cancer, very close to what we found in the Oracle trial. And when they looked at that, they were able to change management and push a lot of patients into surveillance. We don't have all the follow-up data in regarding whether a few cancers were missed and if they were able to follow those and surveil those. But we do have data from that abstract that suggests that a lot less invasive testing was done. In a commercial data set, that this is what's happening sort of out there. Again, the numbers are very, very close. And so I'm starting to sort of gain confidence that the test is actually doing what it said it was going to do in the initial investigation. So this is some really cool calculator that I was able to work with recently, and this is totally unpublished data. But if you look at 1,000 commercial patients tested here, now again, all this is saying is how they're reclassifying after the test. This is not ground truth. This is not post-biopsy. This is not surveilling them to know exactly where they ended up. But if you look at the blue lines, these are the patients here in that 40+% pretest probability of cancer. And then you can see downwards here. If you just look at all 1,000 patients, what you see is that you can start to see this group of dark green down at the bottom here of patients that get pushed down into that lower pretest probability of cancer after their post-test, after they have the plasma test performed. So that's pretty interesting, right? Like you see these patients who are at the, in this risk category pre having the classifier, and they're moved down. Are they moved down enough for doctors to say, hey, look, I'm willing to surveil? Well, that's up to the individual physician, their patient, and what they feel like the risk of cancer is. There may be times where you just don't believe it. And there is this group that's going to end up staying in the intermediate range where the classifier just isn't able to give you any discrimination. If you take the group that started out of those 1,000 and you take the group that started in a bit lower end, and you said, I want only the patients who have a 98% NPV, that's where the test comes back likely benign. What you see is, man, does it move them the needle and moves them down below that 5% risk. Now, again, I don't have the ground truth on these patients, but I do know that, at least I know that the classifier is putting them into this lower risk category. This is a group of 479 nodules where we said, look, the biomarker came back reduced risk, not 98% NPV, not likely benign. This is a group that's indeterminate, and what I would say, if this group of patients that had the blood test and moved across 177 patients where it didn't change, those are patients you have to manage on your own. The biomarker wasn't helpful in that group. I want to share with you a study that we're getting ready to start. And so this is a true clinical utility study. It'll be the first randomized controlled trial of its kind assessing a biomarker. And I'm really excited about this study because this is going to tell us whether doctors really change their minds significantly. And so in this utility study, there'll be a 2-to-1 randomization. All patients will get blood drawn at the beginning of their care, so they turn up with a new pulmonary nodule in the practice. It's a multi-center 30-site trial. And in the intervention arm, they'll get the result of the biomarker before they do anything. And so if they get a likely benign result, we would obviously recommend surveillance. They certainly don't have to follow that. In an intermediate result, which is a non-diagnostic result of the biomarker, they would just stay in their standard of care. And the control arm, they won't get the results of the biomarker, and they'll just do what they would have done initially. The end result of this trial is a reduction in invasive biopsies or surgeries for benign disease. And again, of course, what we would also do is make sure that patients who had a likely benign diagnosis but turned out to have cancer, that they weren't adversely affected by that. But again, those patients should end up in the surveillance group. So really excited about that trial. Probably be a couple of years before the results of that trial are available. There is a rule-in biomarker, and Jim Jett's one of the investigators who's worked on that for a while. And this is an autoantibody, and it can aid in early detection. And then again, a rule-in would have a high specificity. So you see where this biomarker, a 7-panel ELISA test, has a high specificity and yet a low sensitivity. And perhaps combining these two tests, the notify the early rule-out test with this rule-in test, would help maybe on both ends of the spectrum. Not a ton of data out on this, and so we don't have large observational trial yet to tell us that the rule-in test would really significantly change our practice and push patients earlier to get surgery because they have cancer, as opposed to the rule-out test would push us to surveillance. So I'm going to end up here in the last couple of slides by telling you what I think the perfect biomarker would be. So I'd love a biomarker that has an incredibly high sensitivity and specificity, higher than 95%. If I had to pick one, I like the high sensitivity, high negative predictive value, and rule-out test, because I think it really saves. First of all, 75% of nodules that see us in pulmonary practice are benign, so it would help affect more patients. Secondly, I think we're really pretty good at knowing when it's cancer and sending patients off to have surgery. But a rule-out test might really take us away from doing invasive testing on patients that have benign nodules. I'd like my test to be reliable, reproducible, and provide useful information on the majority of patients. So I did show you that in a certain group of patients, you're going to have an indeterminate before and after. It's just not going to help you. I'd like to make that as low as possible. I want a fast turnaround time. I think patients really don't want to wait when they think they have cancer. I want the results portrayed in an easy to understand manner, so that when a doctor gets it, I like that little sort of dashboard speedometer, if you will, where it went from hey, this is 30% down to 3% or so. And I'd love it to be a low-cost test, so it could get utilized by all patients. So I want to conclude right now and say that look, this is a really common problem, 1.5 million and rising nodules in the United States. There's a lot of imaging strategies. The one I'd like you to think about is volumetric measurements. Multiple minimally invasive and surgical approaches, but management really is based on your sort of good detective work, and I think docs are great at this, your pre-test probability of cancer. I think where biomarkers are going to help is they're going to help build our confidence, physician confidence. I think if you are sort of on the fence and saying, I'd like to follow this thing, and you had a really reliable rule-out biomarker, you'd say, oh, well, that combined with my own sense of where we're at, I feel really comfortable at least waiting 3 months and repeating a CT scan. And I actually think the answer here over the next couple of years is going to be with us escaping our silos of radiologists working on Radiomix and interventional pulmonologists looking at bronchoscopy, and geeks like myself looking at prediction modeling, and biomarker people looking at their own. And like, what if we could sort of put a data set together utilizing all of that, and maybe make it into a deep machine learning where the patient comes in, they have a nodule, we do a biomarker test, we tell them they're going to have them back in 3 months, we do some volumetric measurements at 3 months with the result of the biomarker, then maybe we don't even have to follow them at all. So that's where I think artificial intelligence is going to come in here. So I think that comes to the end of my talk, and I think I'm going to stay online and answer answer a bunch of questions. I hope there's some questions anyway. So I'm going to ask the organizers to help me with that.
Yeah, sure. So they are in the chat box, but I could also read them off to you if you'd like.
Okay, let me look at the chat box here. No, why don't you start reading them and then I'll see if I can find them in the chat box.
Sure. Why is the Mayo model used considering it was based off CXR?
Okay, so that's a good question. Actually, the first Mayo model was based on chest radiographs, 1997, Swenson Archives of Internal Medicine. It was actually revalidated on CT scans later on. So that's a good question, but it has been validated in CT, and so I think it's quite reliable for CT scans. Next.
What would be the best model for lung cancer screening?
I like the Brock model, so that's Martin Tamimagi. You can also get that online if you go to look up Brock University model. And why I like that model so much is it was produced and validated in a screening cohort. And by the way, there's no disrespect to Steve Swenson, but if you could look back at the Archives of Internal Medicine article and even the validation article, there were actually the number of patients in that cohort was actually quite small. If you look at Martin Tamimagi's model, and he's a brilliant epidemiologist, and biostatistician, his was done in well over 1,000 patients and validated in even more. So I like the Brock model for screening. The prevalence of cancer is quite low in that Brock model, and that's what you're going to be looking at when you're looking at screen detected nodules. Two different cohorts. I like the Brock model for that. Next.
How much of the difference in diameter was attributed to reader variability, and how much was attributed to the CT sampling? If the longest part of the nodule was between slices on one scan and caught fully by a slice on the following scan, then a lot could come to luck of the sampling.
Yes, that's a great observation. So it's both, though. It's both that, respiratory variation, particularly in small nodules between scans, and if you have thick cuts, you can get this partial voluming. You get this whole thing where you're between scans, you get a lot of variability. On the other hand, and that's especially true of small nodules. On the other hand, there's been plenty of reader studies that show that based on whether you're a dedicated chest radiologist, whether you're young in your career, residents versus attending physicians with a lot of experience, you see a lot of inter-reader variability. So it's a bit of both. And I think that's why automated volumetrics takes all of that out of the equation. If the program works well, it takes a lot of that out of the equation. And so that's why I'm sort of becoming a big fan of volumetric measurements. Next question.
I find that surgeons will want a biopsy prior to robotic surgery, even with high probability nodules, as they do not take it out first, but directly proceed to lobotomy.
Lobotomy is something that I probably could use. That's a resection of the brain, but lobectomy is where you take out the piece of the lung. Yeah, that's been an interesting thing with surgeons. Just so by the way, surgeons manage nodules completely different than we do. They don't look at pretest probability. You go to a Buick dealership, they'll sell you a Buick. They want to operate on all these patients. But I've actually seen this trend at my own place where if they're going to do robotic surgery, and sometimes even VATS, and they're going to have difficulty finding the nodule, they don't like to do a lobectomy without a biopsy. I actually kind of respect that. I think if they aren't completely convinced it's cancer and they don't want to take out a whole lobe, I think it's a reasonable request on their part. Look, sometimes you just can't. Sometimes you just can't reach the nodule either bronchoscopically or with a needle biopsy. But I don't think it's unreasonable to make that attempt. And I was not so convinced of that before I saw some of the data around the number of benign nodules in that upper risk category, right? And so to do a lobectomy on a benign nodule that has a 30% or so chance of being benign, even if their pretest probability is above 65%, I think it's not unreasonable. If it's really high, I try to convince them to make a go of it. But even sometimes there, we're wrong. So yeah, I think it's a discussion for you and your thoracic surgeon, but I'm not opposed to them asking for a biopsy.
How do you utilize the cancer prevalence risk to determine what lung nodule risk calculation model to use?
Yeah, so I work at a VA as well, and in the VA, there's a really high prevalence of cancer, and in that state, we'd use the VA model. I can tell you though that for incidental pulmonary nodules, the Swenson model works really well in a prevalence of around 25%. Again, that's the same we were talking about before. If it's a screen detected nodule, go down to the Brock model, which has a prevalence of 3 to 5%. That's how I distinguish the two. But remember, these prediction models are guidance documents, right? You're just as good in your own intuition as saying, hey man, look, this is an upper lobe spiculated nodule in someone with a 50-pack year history of smoking. Nodule's 1.9 centimeters. Man, like that's going to sway you so much further to cancer. Unfortunately, I see these 35-year-olds in my clinic that come in crying because some ER doc has said, hey, this could be cancer, and it's a lower lobe, well circumscribed, 1 centimeter nodule in a never smoker. I mean, we all know what that is. That's just a benign granuloma or something like that. So I think it's important for us to use these predictive tools as guidance, and not taking away our clinical skills and intuition. Next.
In the pan-topic study, was the evaluation of nodules prescriptive? That is what the threshold to biopsy similar across the centers?
Yeah, so there was no prescription. People did whatever they would normally do. We did not, in the panoptic study, which is, again, we got the blood test. I saw the patients in clinic, so did the other 30 or so sites. We saw patients in clinic. We drew blood. We did whatever we would normally do, so there was no prescription. We never got even the ACCP guidelines, right? We did what we would normally do in our clinic. And never got the results of that test until the end of the trial, when we were writing up the trial, and that's when we could see what happened in that odyssey of patients and what would have happened had the results of that blood test been followed. So that was an observational trial without clinical utility, which is why we're moving to this randomized trial now. Next.
What biomarkers can we use currently in our practice?
Yeah, so the biodesics, this is that panoptic study. The Notify biomarker can be used in your practice now. They also are coupling it. The company has the rights also to that early CDT, which is the rule-in biomarker. So you may get the results for that too. So it's commercially available right now. There are issues around insurance coverage. I think the company will work with people on that, but that is commercially available. There aren't many other tests at all that are commercially available tests that I'm aware of. So that is commercially. Also for the bronchoscopic genomic trial, the Percepta, that is also commercially available and covered by health insurance. So if you're doing a bronchoscopy and you're worried it might be a non-diagnostic, getting that bronchial brush specimen, and that company is Veracyte that has a Percepta, that's available commercially as well.
And then we'll just take one more question here. Does the presence of infection, certain medications interfere with the test?
No, it doesn't. These tests are not related to inflammation or infection that we're aware of. No, we didn't see that in the trial. In either trial, for that matter, either the bronchial genomic classifier for bronchoscopy or this.
All right, well, that's all we have time for today. I'd just like to let all of you know that this recording will be made available to you. It will automatically be sent to you tomorrow afternoon. Thank you, Dr. Silvestri, for your fantastic presentation, and thank you to all whom attended. Have a great afternoon. Bye for now.
You're welcome. Thank you.